So good morning. I'm honored to be presenting this work on behalf of my colleagues at Kenyatta National Hospital, University of Nairobi, and the HIV program in Kenya, and our colleagues at the University of Washington in the US. So we cannot overemphasize the continued need to invest in adolescent HIV treatment programs, seeing the higher incidence in this group compared to children and adults, poorer treatment outcomes, largely due to adherence challenges, higher impact of HIV stigma, and poor mental health. The interventions that have been developed and implemented globally have rightly focused on treatment optimization, adherence support, disclosure, and transition of adolescents to adult care, as we've had throughout the conference. While many of these interventions do include HIV literacy components, few studies have attempted to quantify the role of HIV literacy in the outcomes they produce. An example of a successful intervention was the ATTACH study carried out in 2019 to 2020 and had two components: a disclosure support cartoon book and a transition support cartoon book. So why I take my medicines and take in charge. So this package, named the Adolescent Transition Package, was evaluated in a cluster randomized trial in Kenya and was found to improve transition readiness. The disclosure component was focused on adolescents in HIV care who did not know their HIV status, while the transition intervention focused on youth ages 15 to 24 who knew their HIV status. The transition component intervention had components such as HIV literacy, communication, independency care, and others. So we will focus on the HIV literacy component for this presentation. The main outcome we are interested in is viral suppression. And so we describe HIV literacy among youth in this age group, 15 to 24, determine covariates of undetectable viral load, and specifically assess the effect of improving HIV literacy on undetectable viral loads. We utilize generalized linear models for the inferential analysis, and note that we only included those with detectable viral loads at baseline to determine the effects of improving HIV literacy. More than 2/3 of young people included had been on ART for 5 years or less, so this was a group that was relatively new to the HIV program. And only 13% had been transitioned to dolutegravir in that period between 2019 and 2020 when this study was done. Other factors are very common in a basic HIV clinic. So this graph shows us the differences in 5 HIV literacy domains that were assessed at baseline and 12 months later. We see significant improvements across all domains, but notably youth could explain what HIV is. They could also explain how ARVs work, and we see there was a big shift in the 1 year. And they could also explain what it meant to have a suppressed viral load. But we saw smaller improvements where adolescents noted knowing the names of their ARVs, and defining the cutoffs for viral suppression. So whether you're suppressed, what really is that cutoff? So we created an overall HIV literacy score, combining all these components on a linear scale, ranging from 0 to 10. And we saw that the mean change at month 12 from baseline was 2.45. Intervention clinics had a significantly higher difference in HIV literacy than the control clinics, and this was shown in the results of the main study. So the blue bars in this graph represent undetectable viral loads, that is below 50 copies per mil. The orange ones low level viremia, and the red ones unsuppressed, which is above 1,000 copies per mil. There was very minimal change in the orange bars. That is the low-level viremia group, but we see significant reductions in the unsuppressed and significant increases in the undetectable groups. So that is why we saw the shifts in the 1 year. And we did not see any differences in the intervention and control groups for the main study. This is a bit busy, but the forest plot is a representation of the analysis we did with the baseline data. We looked at the relationship between various factors that are listed on the left and undetectable viral loads. So factors with a significant association adjusted for age and gender, while the duration on ART and duration since disclosure, where higher duration was associated with lower likelihood of having an undetectable viral load. The longer people were in the clinic, the less likely they were to be suppressed or have an undetectable viral. The difference is significant there. Compared to young people still receiving treatment support from caregivers, those who were independent had a higher likelihood of having an undetectable viral load. And as expected, those at a higher WHO stage had lower likelihood of having an undetectable viral load. But very counterintuitively, and that is the very last one, the very bottom, a higher literacy score at baseline was associated with a lower likelihood of having an undetectable viral load, and we'll discuss possible reasons for this. So on the other hand, we found no effect of improving HIV literacy on undetectable viral loads at month 12. That is 1 year after we enrolled them. And this was specifically for those with a detectable viral load at baseline. So we just looked at that group and saw whether improving their HIV literacy helped them. We show on this table results for the stratified analysis by arm and include results that are shaded in orange for the continuous exposure variable, and then we have the categorical variables just below there, basically just showing that we had little effect of HIV literacy on having an undetectable viral load. And so in conclusion, we note the significant improvement in HIV literacy over the 1 year, especially in the intervention arm, highlighting the benefit of interventions such like ATTACH. But we saw an inverse association between HIV literacy and undetectable viral load, likely because HIV literacy interventions focus mostly on those who have poor treatment outcomes. We basically just focus on them and give them a lot of information. Meaning that at any point when you cross-sectionally look at the people who have better knowledge are those people who generally are not doing very well. Improved literacy, however, had no significant effect, and this highlights the need to complement these interventions with other behavioral and biological interventions, especially for subgroups with risk of non-suppression. I wish to thank the ATTACH team that worked really hard to provide us with this data, our participants, and our funders, the NIH. Thank you.